Hello and welcome to the Musella Foundation Brain Tumor Webinar Series. Tonight's special guest speaker is Dr. Nick Blondin. Dr. Blondin is a neuro-oncologist at the Yale Brain Tumor Center and associate professor of neurology at the Yale School of Medicine, and he also leads the Yale Neuro-Oncology Clinical Research Team. Dr. Blondin, thank you so much for joining us. Please take it away.
All right. Thanks so much to Vanessa and Al for the opportunity to present this work, Nano 2 for glioblastoma. For full disclosure, our site, Yale University, enrolled patients into the RESTORE study of Nano 2, but I have no personal financial interest in this product. I'm giving this program as an educational program with no compensation. So we all know glioblastoma is a difficult to treat cancer that is rare, but not very rare. Most people know someone who is affected by glioblastoma. And unfortunately, treatments haven't substantially improved in the way other cancers have over the last 10 years. The prognosis for survival generally is still less than 2 years for a newly diagnosed glioblastoma patient. And there's a very high rate of recurrence of this disease after initial treatment. Essentially, almost all patients will have a recurrence of the tumor, progression of the disease after initial treatment. And GBM is difficult to treat because it can develop as a tumor mass and also infiltrative diffuse tumor cells in the brain. And typically, even at diagnosis, both of these are recurring. So in this example of an MRI at discovery, the patient has a contrast enhancing mass in their left temporal lobe, and really a kind of a darker area in the center of this mass where necrosis has happened, a process where tissue can die from lack of oxygen and rapid cell growth. So this contrast enhancing area represents the tumor bulk, growth of cancerous cells. But on the inner edge of that, or medial to where the mass is in the brain, all abnormal signal can also be seen on other sequences like FLAIR due to different tissue density here. The infiltrative tumor cells are mixed in with normal brain, making the tissue denser, and it will appear on scans like this. So we can see that the problem is both the primary tumor and the infiltrative disease. And surgical strategies focus on really just removal of the visible tumor, the contrast enhancing tumor. So even after a gross total resection of the mass in the left temporal lobe, residual infiltrative tumor cells will persist. And really, essentially, in all newly diagnosed glioblastoma patients, there's some residual infiltrative cells. And these are what we need to treat with further therapies like radiation and chemotherapy. Under the microscope, glioblastoma looks like a very cellular tissue. All of these purple dots mixed in this pink matrix represent cell nuclei, the center of cells where DNA is located. And on this top half of the slide section, we actually have cells migrating away from a relatively acellular area referred to as necrosis. In this area, there's very low oxygen concentration, and so cells can't survive here. Cells need oxygen for normal cellular functions and be able to copy the DNA and divide into new cells. So the cells try to migrate away from hypoxic areas, resulting in necrosis. And they also release growth factors like VEGF as a hormone to stimulate blood vessel growth. That's a process referred to as angiogenesis. And we can see this angiogenesis or vascular proliferation occurring on the bottom half of the slide. In these areas where you see kind of this reddish small dots, these are actually blood vessels that have some thrombosis in it or coagulation of the blood in the vessels. So even though the vessels are growing, blood is not flowing normally through them. And so when blood flow is not occurring normally, oxygen isn't being delivered to the tissue, and the tissue has low oxygen, which we refer to as hypoxia. So radiation is the most effective treatment for glioblastoma. It's more effective than chemotherapies that exist at this point, and that's why radiation is recommended as the upfront treatment for glioblastoma. Radiation can damage DNA, causing single strand breaks. or even double strand breaks. DNA is a a helix molecule, and it has two strands. So when the radiation will hit the DNA, it can break one of those strands. But the cells have DNA repair mechanisms that can repair single strand breaks. And another mechanism, radiation can hit oxygen and cause these things to develop called oxygen-free radicals. Oxygen-free radicals are um, ions that can also lock in that DNA damage and prevent the cell from healing normally. So in areas where there's normal oxygen, referred to as normoxia, there's a lot of oxygen radicals that are formed, and that DNA damage gets locked in, resulting in cell death. In areas that are hypoxic with low oxygen concentrations, there's less radicals, and so the cell has a better chance of repairing itself. And unmethylated glioblastomas or MGMT unmethylated glioblastomas have a better repair mechanisms, and so that's why they are particularly resistant to treatment and generally have a shorter prognosis for survival. So, knowing this, what we want to try to accomplish is increasing the oxygen concentration in the brain tumor area to make radiation more effective. And so, this finding that inside GBM, when there's oxygen deprivation or hypoxia, tumors need more radiation to work is actually more than 70 years old. This isn't a new finding. This was identified in the early 1950s in tumor cell cultures that were exposed to normal oxygen or hypoxic low oxygen conditions. Cells, cultures that were in normal oxygen needed lower doses of radiation to achieve cellular killing. Those in the hypoxic areas require almost like three times as much radiation dose to kill them. So these cells, are just more radiation resistance. And within glioblastoma tumors in humans, this is what we're seeing. These are hypoxic tissues, and radiation may not be completely effective to kill all the cells. So again, we want to restore oxygen to the tumor area before each radiation session to make the radiation work better. And so the way that we're trying to accomplish this with this product Nano 2 is to deliver more oxygen to the cell through circulation. But the Nano 2 is a fluorocarbon nano droplet. Nano 2 stands for dodecafluoropentane emulsion, or DDFPE. It's a fluorocarbon nano droplet. It's about 1/40th the size of a red blood cell, and it has high oxygen carrying capacity. Due to the nature of the nano droplet, it can sequester oxygen molecules inside it. Oxygen stays in there and then will diffuse out into hypoxic areas. Oxygen is otherwise normally carried in hemoglobin molecules in red blood cells, but because of that thrombosis I showed earlier on the slide, red blood cells can't get to certain tumor areas, and that's why hypoxia exists there. So the Nano 2 itself is really just the carrier. It's not a cytotoxic molecule. It doesn't directly kill cancer cells or really alter their metabolism any way. It's just delivering oxygen into the brain, specifically into the hypoxic brain tumor area to try to make radiation more sensitive. And this product was also been studied over the last 20 plus years. It was initially studied as an ultrasound contrast agent in over 2,200 patients. It was found to be safe in that study, and the product is metabolized by being breathed out through the lungs. So for glioblastoma treatment, patients receive the Nano 2 infusion as a liquid. It's given via an IV infusion over 5 minutes. And as it's infused, the molecule will form these nano droplets in the body. The droplets pass through capillaries in the lungs, pick up oxygen, and then they circulate throughout the body and release the oxygen in hypoxic tissue. Then, as time goes by, the Nano 2 is just kind of like excreted from the body just through normal respiration. So preclinical work was done in mouse models, just sort of proof of concept here that we can increase tissue oxygenation with the Nano 2 and oxygen for patients. So in one study, in a mouse pancreas cancer model, tumor oxygen initially is near zero, but then after being treated with IV nano 2, the oxygen did raise substantially into the tumor cells. And that took place over like a 20 to 30-minute period of time. This was also looked at rodents in a glioma model treated with nano 2 and a carbogen, which is 95% oxygen and 5% CO2, and radiation. And these tumors seem to be like very susceptible to radiation, and the mouse survived longer that were treated with this product. There's also a model looking at hepatoma, again, where nano 2 and carbogen completely reversed radiation resistance in those tumor cells. So this looks like an effective therapy in preclinical models, and so we wanted to translate it into humans. And so when nano 2 is given, it takes some time for it to pick up oxygen and then distribute it in the body. And we found that initially when nano 2 is given, it takes some time for the hypoxic tissue to normalize. And so it plateaus around 60 to 90 minutes. And again, this is based on one of these preclinical models. But we think this is also true in humans. So we want to give nano 2 and have the patient breathe supplemental oxygen and then wait 60 to 90 minutes to let the tumor tissue oxygenate. And we actually can see this with certain MRI scans. I'll show you that on an upcoming slide. But the effect is real. This can kind of normalize hypoxic regions of brain tumors. So it's important for nano 2 to be given with supplemental oxygen. So again, nano 2 is the critical factor that like the carrying nanoparticle for the oxygen. And then we have patients breathe oxygen just through a nasal cannula prior to treatment. So patients have an IV placed, receive the nano 2 injection over 5 minutes, and breathe supplemental oxygen for about an hour, and then continue that until the end of the radiation treatment. And then radiation is usually delivered in daily doses or fractions over about a 5 minute period of time. So the whole process is sort of completed usually within 90 minutes per day of treatment. So this adds some time to the daily treatment for patients, but again, it's like a fairly straightforward procedure. And yeah, we think that it can reoxygenate the tissue. So a phase one study has been completed a few years ago. In the phase one study, 11 patients with newly diagnosed GBM were treated. They all received nano 2 with standard radiation and temozolomide chemotherapy. And the study showed that treatment's feasible and it appeared to be safe. There were really no significant nano 2 related adverse events that were discovered, and the dose was selected for the phase two study. They looked at some survival outcomes in this study. Again, it was just 11 patients, so a pretty small study, but it seemed like nano 2 possibly was helpful in this patient population, or at the very least was not like harmful to patients. So again, from a small study like this of just less than a dozen patients, you can't really draw firm conclusions on survival advantage or efficacy, but we can see like safety signals, and then it just preliminarily, it appears that treatment like possibly is effective. In the phase one, it extended the median progression-free survival from a historical control of about 7 months to 9.6 months. I hope I'm not freezing there. About 7 months to 9.6 months. And overall survival was found in that study to be 19.4 months. Again, a few months longer than the historical control. So the product moved into a phase two study called the Restore study. Oh, first off, this is the MRI that I mentioned a little earlier in the deck. There's an MRI capability called TOLD, T-O-L-D, standing for Tissue Oxygen Level Dependent MRI. And before nano 2 is administered, in this image, the brain tumor has low oxygen within the center and like probably a necrotic core. and then the surrounding tissue, like this whole region here in the left frontal parietal area of the brain is hypoxic. Normal brain oxygenation is the kind of this bluish greenish color. And again, the brain has a lot of folds on the surface called gyri and sulci. So right around the edge of the brain, also that's hypoxic where spinal fluid is. So before nano 2, we're seeing this hypoxic area. And then after nano 2 infusion, you have a lot of basically normalization there in most of the tissue. So a small area of hypoxia does persist kind of lateral to the tumor, but the majority of the tumor has been like reoxygenated and it has like normal O2 levels. So this has been shown in like a number of patients that underwent told MRI imaging as part of the clinical development of this product. So it's good to see this like imaging to prove that the product is working as intended. It's increasing oxygen in hypoxic brain tumor regions. So after the phase 1 study, a phase 2b study was initiated, which is called the Restore study. In the Restore study, the design was to enroll 93 patients over a number of sites. Actually had 12 sites enrolling patients. Again, Yale University, where I work, was one of the sites. And the study was a randomized and controlled study. The randomization was a 2-to-1 of experimental product nano 2 versus a saline injection. So all patients received an injection, all patients received supplemental oxygen treatment, but two-thirds received nano 2 and one-third received saline only. Again, we want to try to look at overall survival outcomes and see if there's like a survival advantage to giving nano 2 versus the saline. So the primary endpoint is progression-free survival, or the time from diagnosis until the first relapse occurs. And that's what we're kind of looking at. We're hoping that treatment with nano 2 increases the time of that progression-free survival. So to enroll, patients had to have a diagnosis of glioblastoma based on current criteria. Patients were at the newly diagnosed phase after surgery, but before starting radiation therapy. Patients had to have a reasonable performance status, meaning that they had no mild or moderate disabilities. Patients with significant disabilities were felt to be not suitable candidates for clinical trial treatment. And then those are really the main inclusion. Again, newly diagnosed glioblastoma before radiation and reasonable performance status. And then there were stratifications were done for MGMT methylation status, unmethylated or methylated, a formal prognostic score for the patients, and then use of Optune for maintenance treatment. Patients were allowed to use Optune for maintenance treatment after completing the radiation and nano 2 phase of the study. Patients would receive standard radiation, which is 30 fractions or 30 doses. That's the 6 weeks period of time. Patients would undergo MRI before radiation, after radiation, and then at various time points in maintenance treatment. Here's kind of a schema of that study. Again, patients were screened, would undergo an MRI within 10 days of treatment start. Factors like MGMT were resulted prior to the randomization, so we had those like stratification factors. Patients would be randomized. This was blinded to the patients and also to the investigators. So while we treated a number of patients at Yale on study, I actually don't know which group they were in. All the investigators and patients were blinded. Only our research pharmacy staff was aware of the treatment the patient was on, and we felt that this was critical to maintain scientific integrity of this project. So patients were centrally randomized by the study, would receive their study treatment along with radiation, and then they would go into a maintenance treatment with temozolomide in the standard 5 days on, 23 days off paradigm for up to 6 cycles. And then patients are followed, like up until the point when the progression happens. At that point, they would complete the study and could go on to alternative therapy. So this study actually completed enrollment. Fortunately, all 93 patients have been enrolled and they completed nano 2 treatment. So patients are in follow-up at this point. They're in maintenance treatment or they met their endpoint or being followed. The 77% of the patients are still in follow-up. So right now, this time is just elapsing. We're sort of just waiting, for endpoints of progression to occur in patients. And the data readout is expected upon reaching a certain number of endpoint events. Currently, it's estimated to be potentially the fourth quarter of this year, so like later this fall or over the winter potentially. We kind of estimate we'll have the results. The drug itself seemed to be extremely well tolerated, and excellent safety profile. So these kind of side effects are like symptoms patients are experiencing are captured while they're on their clinical trial treatment through study visits, daily while they're receiving Nano 2 with radiation. And there were actually no significant or serious adverse events associated with Nano 2 in the patients. There was like no causal relationship between the product. Um, and I can say from my own direct experience, patients seem to tolerate the infusion extremely well. Patients tolerated oxygen well, as you would expect. Um, some side effects do occur in patients undergoing radiation and treatment, radiation and temozolomide treatment, and these are what are captured with AEs. The primary side effects experienced in patients are lab abnormalities, which are referred to as investigations, and nervous system symptoms. So these could be like neurological symptoms or disabilities, like generally attributed to glioblastoma, including headaches, dizziness, weakness, imbalance, or seizures. The other rate of side effects is relatively low, like 7% or lower for other organ systems. And that seemed pretty typical for standard glioblastoma treatment with radiation and chemotherapy. So at this point, the Nano 2 has completed the phase 2 Restore study. We're waiting for the readout. And from that point on, there are discussions are ongoing on how to design a pivotal study, or called a phase 3 study. And the goal of the pivotal study would be to prove that Nano 2 can improve patient survival when used with radiation and temozolomide in newly diagnosed glioblastoma. Nuvox is also has approval from FDA to investigate Nano 2 and radiation in recurrent glioblastoma, and there are considerations for a phase 2 study in this population that are currently ongoing. Nuvox also has a program of expanded access potentially available to patients, and interested patients in this should reach out to Nuvox for an inquiry. They can be reached at nuvoxtherapeutics.com and then clicking on the contact button to submit an inquiry. Okay, it looks like that's the end of the slide deck, so I will stop there, and I think have Vanessa
Yeah,
run the Q&A part.
that was fantastic. Thank you. I'm not sure that my audio is going to hold out, so if it gets glitchy, let me know and I'll take over.
It's fine
Um,
right now.
okay, good.
It
Okay.
sounds good.
I hope
We do
I
have
hope I
some
was clear.
questions, so I'll get started. Okay. In the Restore study, how did you define progression? And did you see more pseudo progression since the radiation therapy was working better?
Well, that is a great question, and good. I was intended to comment on the pseudo progression question. So progression is defined by MRI endpoints. The RANO scoring was used as the endpoint. We used the RANO 2.0 criteria. So essentially, that's like enlargement of the contrast enhancing tumor by more than 25%, or development of new measurable contrast enhancing tumors. And then for patients of uncertain progression or possible pseudo progression, they would can have a follow-up scan to look back and see if there was that's confirmed progression or not. Sorry about that. With the pseudo progression question or radiation treatment effect, yes, the Nano 2 by delivering oxygen and causing more oxygen-free radicals to exist could increase chances of pseudoprogression, radiation treatment effect, and this is something else being monitored within the study. It's not a formal endpoint, I believe, for the study, but it's something that's being looked at. Again, with 93 patients on study, that we can look at every case to identify potential pseudoprogression, where there are higher rates of pseudoprogression. Um, Sometimes when pseudoprogression occurs, it could be treated with steroids or other type treatment, and then patients may end up getting like a survival advantage, like ultimately from that. Of course,
Mm,
you'd want to prevent pseudoprogression from causing like more significant brain injury. Um,
of course, yeah.
so it's a kind of like a balancing act by the treating neuro-oncologist to know how to manage that. Um,
Okay.
so is the pseudoprogression itself is not really from nano two. It's like from radiation treatment. But again, that is like being monitored in patients that were treated.
Okay. Would it make sense to use the Nano 2 together with stereotactic radiosurgery?
Um, that is a question that I feel like I do not have enough expertise in terms of radiation oncology to know the answer
Okay.
to. You give a higher dose with stereotactic radiation. Um, Yeah, not totally sure though on that. I'm not aware of any patients that were treated with nano 2 and stereotactic radiation either.
Okay. Um, the told MRIs that you showed us were really neat. I've never seen those before.
Yeah, I'll
It,
go back to that slide.
is the oxygenation as imaged with the told MRIs, is that its own endpoint? And
It
are those MRIs generally accepted as, showing what they purport to show?
it was in like a extra endpoint. It wasn't a primary endpoint. It was like an experimental endpoint.
Okay,
The
okay.
told MRI is not available at all institutions. For example, at Yale, we did not have the software for told MRI, so we did not participate in this. But at other centers that did have told MRI capability, patients were encouraged to participate in this kind of like ancillary part of the study. And yeah, like this is one slide of a representative image, but this was seen with a number of patients as kind of a proof of concept that again, like this is the oxygenation area, all the blue within all this white matter. And then here in this tumor area that you saw is hypoxic before nano 2 becomes,
Mhm.
oxygenated. Still not 100% though.
Yeah, I was going to
Again,
ask that as a
yeah,
follow-up question. Is it mostly just at the core and you're not getting kind of the tumor periphery?
Yeah, looks like it's kind of like around, like maybe this was like a necrotic core right in the middle. Then this was like an extra hypoxic area around there. And then this part back here, like kind of further out, for whatever reason, still didn't oxygenate as well as this kind of like inner ring. Um, there may be various factors like capillary formation that's different in different tissues, tissue density there.
Sure.
Yeah. So
Okay.
the tiny size of the particles allows them to diffuse into hypoxic tissue where red blood cells can't get to. And that's part of the kind of like the magic of this particular nanoparticle.
And I was going to ask, because you mentioned the Carbogen preclinical evidence. I
Yeah.
thought they did a human trial with Carbogen and maybe it had mixed results. So is Nano 2 better just because the delivery and the uptake is better?
Yeah, if it was only carbogen, carbogen is mostly just oxygen. As far as I'm aware, it's like a 95% oxygen. But then you even if you breathe supplemental oxygen, and like you oxygenate your body, this it doesn't get there into the hypoxic areas because you don't have adequate blood flow that's there normally. Like
Mhm.
red blood cells with hemoglobin aren't going there, so the oxygen just can't diffuse like into that tissue.
Sure. Okay. Could improving tumor oxygenation make GBM more immunologically active or more responsive to immunotherapy?
I think that also is an area under investigation. Um,
Okay, okay,
I my just personal opinion would be possibly.
okay.
Um, there's many kind of facets of glioblastoma immunology and immunotherapy treatment of brain cancer that's poorly understood. Like mechanisms of resistance, we don't really understand. Um, and some treatment, like immunotherapies that should theoretically work, seemed ineffective in humans for reasons that are still being kind of looked into.
Okay. For the upcoming recurrent trial, will there be a consideration for patient selection? Like, could you look at patients and the ones that have more hypoxic tumors? Okay, you're a great fit for this study.
I think practically speaking, it would be generally more of like an all-comers
Okay.
kind of study. I don't know that we would really want to limit that study to like a certain recurrence. And
Mhm.
also, I think that thought needs to be given to what the endpoint should be exactly. So for recurrent GBM, um, obviously we as neuro-oncologists want the patient to survive as long as possible, but also with the best quality of life for as long as possible. And so in recurrent GBM studies, just due to the nature of GBM and the neurological disabilities a patient could have, using survival as like the endpoint can be tricky. And there can be factors kind of independent of the glioblastoma directly that impact patient survival, like
Sure.
weakness, risk of falls, DVTs, things of that nature. So we may want to use other surrogate markers like told MRI or um, just something different than like what you would want to study in newly diagnosed patients, which really is like progression-free survival. I
Mhm.
think is like the gold standard nowadays in newly diagnosed GBM studies.
Okay. Well, I have to say we really love that the Restore trial allowed patients to use Optune. Now, when you're doing your analysis for your readout for Q4, are you going to look at the compliance, the Optune usage compliance, and kind of factor in that into the results?
Yeah, I think so. So for patients
Awesome.
that utilized Optune, that study data that we want to capture.
Wonderful.
And those reports are should be available in the patient's medical record, so we can know.
Okay. It's sort of related, but sort of not. Hyperbaric oxygen therapy. A lot of patients ask about that because it is something that's accessible outside of trial. How do you feel about that? Do you think it works? Do you think it helps together with radiation?
Well, I think hyperbaric oxygen is still a therapy that's under investigation. I would say it hasn't been proven to be effective for glioblastoma or glioblastoma related symptoms. Um, I think that there is some possible risk that hyperbaric oxygen can cause seizures to occur. And if a seizure occurred while a patient was getting treatment, it's pretty dangerous. The patient's like in the chamber, and you wouldn't want to like decompress too quickly.
Yeah.
So for any patient considering hyperbaric, would like strongly advise using like anti-seizure medication,
Hmm.
at least prophylactically, if not therapeutically. But I think that the the jury is still out on is hyperbaric a helpful treatment or not. I think it's an area where we need to do more like learning and discovery.
Great. And then I guess for a final question, is there anything else, any other research you're involved with that you're excited about, whether it's other clinical trials or adjuvant therapies?
You know, the field is moving forward for glioblastoma. We've been a key center for the GBM Agile study, which I'm sure you're familiar with multiple arms, different arms for different investigational products.
Hmm.
One of the national co-PIs for the ADIPEC 20 arm of that study. We feel like that study has been a good way to study therapeutics quickly. and in like a standardized fashion. So I like the concept of that study, the GBM Agile, and I hope it leads to it like a breakthrough sooner rather than later with one of the experimental arms.
Mhm.
But I have interest in newer technologies that are still in like early phase development.
Mhm.
That includes CAR T, which I'm sure, as you know, is a very complicated, biological product
Yeah.
to manufacture and treat patients with. But CAR T seems very promising. It's obviously a huge breakthrough in hematological cancers. CAR T is an area I think in GBM under active investigation. There's also newer antibody drug conjugates, which are a class of medication that combines an antibody with a toxic molecule that can poison cells. Antibody drug conjugates have been huge breakthroughs in other cancers like metastatic breast cancer, um, other kinds of like gynecological cancers. And I know in GBM there now are like early phase studies looking at these ADC products.
Okay.
So those are kind of two classes I think over the
Okay.
next few years will have a lot of new studies and new development. I'm hopeful there's a breakthrough, and I'm also hopeful CAR T scales up and is available at more institutions, and just to like a broader segment of patient population.
Okay, great. And someone asked specifically about dendritic cell vaccines. Do you have any
Yeah,
opinion on that?
well, my opinion on vaccines, just overall as a anti-glioblastoma modality, is that it seems that some patients do have response to a vaccine, but it's only a small percentage of patients. And it's not well understood how to select these patients. There's factors related again to brain immunology that can render vaccines ineffective, even if, based on the hypothesis or the mechanism, they should work. So I think as a therapeutic strategy, just trying vaccines without really understanding who can benefit from this or how do we like unlock brain immunology is not really like a going to be a groundbreaking type of treatment yet.
Okay. Well, this has been a fantastic presentation. Thank you so much. Today is actually the 28th anniversary of the Musella Foundation getting our nonprofit status. So it's a
Ooh,
it's a special occasion, and we're glad we got to
congratulations.
share it with you. And we've been doing these webinars for years, but we can't do them without the wonderful neuro-oncology professionals who are doing the research that's helping patients. So thank you.
Thanks so much. We've seen a few breakthroughs in 28 years, but not enough. We need
Not
some more,
enough.
right?
Thank you so
So
much. That was fantastic.
thanks so much for the opportunity again. I really appreciate it. Have a good night.
Thank
And we'll
you.
have you come back when the results are announced.
Perfect. We'll keep you posted, Al.
Okay, bye
Awesome.
bye.
Thank you.
Thanks.